Welcome everybody to, like I said, the March session of our National Urban League's Health Equity webinar series. We're delighted to have these wonderful panelists with us. I will say, unfortunately, one of our panelists, Lynn Roberts, is ill and is unable to join us, but we'll find another way for all of you to connect with her wonderfulness, because she is wonderful. And so we would have loved to have her on this session, but people have to take care of their health and do what is right for them. And if sometimes that means saying no, that's the right thing to do. And so it's actually, I wanted to stress that and put that out there, that we have to make sure that we take care of our own health and that we listen to our own bodies, and that we take care of ourselves in ways that can have us here for a long time to be continuing to do this work. And so as sad as we are that Lynn is not here, I have no problem and very happy that she felt comfortable enough. I've known her for a long time. She actually hired me for my first academic job, just to say that personal thing, that she felt, fine enough to tell us she wasn't going to make it. So many of you know who I am. I'm Lydia Isaac. I'm the Vice President for Health Equity and Policy, the National Urban League. The series is under my division, and we're really excited about it. This is the third one for this year. We just started it in January, and we're just going to start off before we introduce our panelists. I don't know, Lillian, do you want me to introduce the panelists first, or do we want to go to the topic? Do we want to do your topics?
Maybe I can jump in and then let's introduce the brilliant panel and start the discussion right after. I don't want to take up too much time.
Absolutely. So I just want to introduce people again to Lillian Merhan, who is our Horizon Therapeutics health equity scholar in residence at the National Urban League. She's a doctoral candidate. We were just talking about she will defend her dissertation at the end of April, and we're so proud of her, but here at the National Urban League. And so she's just going to give us a nice overview of the issue. And then Nikitra and Tara are going to really get into the meat of the issues. And I'm really excited. I want to particularly say before I introduce her, thank you so much, Tara, for being here, because having somebody who's on the ground doing this work is really important to know what's going on and to really get feedback, best practices and ideas. So thank you so much for taking the time. Lillian, I'm going to pass it to you.
So I want to just give an overview of maternal health, so the topic for today. Give some statistics, to background, so that we understand, why this is such an important topic. And then I will make sure to move along quickly, because I want to hear from our panelists, and I'm sure that you do as well. So what is maternal health? Maternal health refers to the health of a pregnant person during pregnancy, childbirth, and the postnatal period, so the period just after giving birth and for about a month or so afterwards. Each stage should be a positive experience, and the value of maternal health is not just for the pregnant person and their baby, but it's important for our communities, because healthy moms, healthy babies bring healthy communities. And so this is a really important topic, and it's really about ensuring that they're able to reach their full potential for health and well-being. But unfortunately, there are pretty significant maternal health issues and inequity worldwide. So about 1 woman every 2 minutes dies from a preventable cause connected to pregnancy and childbirth. And also, in addition to those 800 folks, another 18,000 people will experience preventable injuries, infections, illnesses, disabilities during this period, and because of complications from this throughout the day. This is per day. And so I'm going to talk about maternal mortality and maternal deaths. They mean the same thing. So maternal deaths is often referred to as maternal mortality, and it's really one of the biggest and most significant areas of inequity. Maternal death is defined as the death of a person while pregnant or within 42 days after the end of the pregnancy, and that's from any cause related to or aggravated by the pregnancy or its management. For many years, the maternal mortality rate in the United States has consistently exceeded that of other high-income countries, and it's actually getting worse. And it's more than 3 times the rate of other high-income, quote-unquote, countries. As you'll see here, this chart is from the Commonwealth Fund, this is from 2020 data. In 2020, out of every 100,000 folks who had a live birth, about 24 of them died in the United States. But this does not tell the whole story. So in the United States, there are overwhelming inequities, with some communities experiencing deaths at a much higher rate. So as you see here, Black people are 3 times more likely to die when pregnant or shortly after giving birth compared to white people. And every 100,000 Black women who give birth, about 55 of them are going to die. 55 out of every 100,000 are going to die because of pregnancy-related complications and childbirth complications, preventable complications. And so let's dive into this a little bit more. So when looking at not just maternal mortality, when I talked about, but also illness and complications, Black women are 63% more likely to experience severe complications during pregnancy and childbirth compared to white women. And when we look at exactly what these are, the big and significant ones are cardiac disease, bleeding disorders, preeclampsia, so high blood pressure, and also Black women are 2 times less likely or more likely to receive little or no prenatal care. So they're less likely to receive prenatal care. And we're going to talk about why. And I want to note that sometimes when these topics come up, the question of like, oh, well, if you have money, does that help you? Well, having money or education is not really protective. Well, not for everyone. So in February 2023, a New York Times article titled "Childbirth is Deadlier for Black Families Even When They're Rich" describes a study that really went into this. And the study took place in California. And it noted that having money can protect white moms and babies, but just white moms and babies. It found that in California, for every 100,000 births, 173 of the babies born to the richest white moms die before their first birthday. When they looked at Black moms, the number was 437. So there are really significant disparities, even when we're looking at wealth. But I want to recognize that when we're talking about numbers, we can lose some of the humanity of what we are talking about. So before turning it back, I just want to talk about a case that maybe you're familiar with, and that's Serena Williams. We know she's famous, we know who she is, and she's a wealthy woman. And also she has a history of blood clots that she had talked about. It's been in the news, but that didn't protect her. So the day after Serena Williams gave birth to her daughter, Olympia, you can see the picture here. This was in 2018. She began to feel shortness of breath. And she'd had a history of blood clots, including a pulmonary embolism, which is when blood clots get into the lungs and they prevent your body from being able to get enough oxygen, which is important. And so she had a C-section, and because of the C-section, she had to stop taking her medication that was preventing those clots, because clotting is important when you're healing from a surgery, when you have a wound. But unfortunately, they didn't consider that those clots might come back pretty quickly. And so the next day, she started feeling shortness of breath, and she knew what was happening. She knew her body. She went to the nurse. She was struggling to breathe, and she told her, I need a CT scan and I need to start medication to treat these clots. But the nurse didn't believe her. She said, well, you're on pain medicine. I think you're just confused. But Serena really persisted and said, no, I need this. Instead of giving her the CT scan to be able to look at her lungs, they gave her imaging of her legs. And of course, that didn't show anything. And so finally they said, oh, okay, well, we'll do imaging of your lungs. And of course, she knew her body. She was right. They found clots in her lungs and they started treating them. But she had gone now for some time coughing really hard. Her lungs were working to get these clots out. And so her wound opened up again and she had to go back into surgery. And because of everything that happened, she spent the first 6 weeks of motherhood unable to get out of bed. And again, this is someone that you'd think, we know who she is, we know she has resources, and this happened to her. And so I want to hear more about, why are these things happening? What's being done to address these inequities, and what can we do to support our communities? And I'm so excited to hear from our panel. I know you are too, so I'm not going to take up any more of your time, and I'm going to turn it back over to Lydia.
Lillian, thank you so much. That was a wonderful introduction. I think the introduction that we needed to get in this conversation. So I'm actually not going to spend time going through both Nikitra and Tara's wonderful bio. Just know that it was in the notice. We can send it to anybody who wants it, but make sure I want to say Dr. Burse is just so eminently qualified and phenomenal that that you all should go and read her bio because it's pretty amazing. And I gotta say, Tara, I love your bio. I love about your baby and your dog, and all you pet parents. I am not a pet parent, but all you pet parents and your dogs, I really appreciate it. But I really want us to get into the meat of this, right? The setup that we have from Lillian is, look at this issue. It's a profound issue that's happening in our communities. And, if it can happen to Serena, it can happen to everybody. So what I would like you all both to start off with is, what brought you to this work? Like, we know the issues, but there's so many issues, right? That, our communities are facing so many things. What brought you to this work, and what do you feel is your passion for doing this work, and how do you do it?
Tara, you can go first, Tara.
Okay, I'll go ahead and go. So many people who do this work, birth workers, it's probably because of their birth. My birth with my daughter is what got me into the work. I was a college student at Mississippi College when I got pregnant. My junior year going into my senior year, I stayed on campus in my dorm while I was pregnant, and I worked 3 jobs. And it was very, very rough, and I did not have private insurance at the time. I don't think I had any insurance. And so navigating that was horrible for me, because I remember when I was setting up my first appointment, I called a clinic. And of course, when people hear my name, it's Tara Clifton, people usually think that I'm a white woman. And so I remember on the phone, everything was great. And then I showed up to the clinic. At the time, my Medicaid still hadn't went through. And the experience was so horrible that I literally got up to leave. And so long story short, I ended up cycling through 3 providers, only because the first provider just was horrible. My second provider, I found out that she was giving me medication that I should have not been taking while I was pregnant. It led to me being in the hospital. They couldn't find a heartbeat with AC. And then a guy in the ER pretty much told me that my doctor was giving me this medication because it would allow me to continuously go back and forth to her clinic, and she was billing me for it. And he told me if I wanted to come out of this situation with a child that was alive, that I needed to get me another provider. And once I got my provider, who is no longer working, everything was good with him. Like at that point in my pregnancy, I was doing all the research. I pretty much wanted an at-home birth, but I knew I couldn't afford it. And so I was just like, I'm going to get as close to it as possible in the hospital. And he had me thinking that I was going to be able to do all of these things. I did not know what a birth plan was at the time. I just was writing stuff down in my notebook, dreaming out loud. And so when it was time for me to have AC, it was in February, flu season. I should have known that something was wrong when they told me, when I called on the phone to tell them like, hey, I think I'm in labor. And they asked me, was I in pain? And I was just like, no, I'm just having a little bit of lightning crotch. I'm fine. And they hung up in my face. I called back and she was just like, well, you'll know when you're in labor, you're not in pain. You can actually sit on the phone and talk to me. You're fine. And so my mom encouraged me to go to the hospital. I got there and they ended up making me sit in the ER with sick folks because they said I was not showing any symptoms, any signs of being in pain. And I sat there for like 3-4 hours until I finally went up. The nursing staff was very, very combative. They ended up sending my mom and brother home because they told me that I was not going to go into labor. And in that time, I did not know that my provider was there. And when he walked into the room after they had left, he broke my water. Though I was sitting there doing my exam, everything was fine. I was progressing. At the time, I was about 5 centimeters and I was taking a full-fledged exam. From him breaking my water, me not really knowing what was going on, everything went downhill. My mom and brother came back, and once they came back, of course, they're trying to encourage me to get an epidural, though I already stated that I wanted a natural birth. It got so bad to the point that my mom was hollering and screaming at the nurses. And when it was time for me to push, because they were so frustrated with me at the time, she ended up telling me that I had wrapped the umbilical cord around my daughter's neck because I did not know how to push. And doctor ran in, no gloves on, anything, just kind of stuck his hand in. And I sat up because I was just like, I'm not going to take this. This is just too much for me because him, they were arguing. And ended up having my daughter. My postpartum experience was not the greatest experience. I was made to feel like I was crazy because I have suffered from mental health issues in the past. I'm a suicide attempt survivor. And so they were looking at my charts, they were looking at my history, and a lot of the things that I raised questions about, even with my daughter landing in the NICU, I was not taken seriously. They put it on the fact that I had some mental health issues going on at the time. And so my postpartum experience was not great as well. So with that, I jumped headfirst into doula work after finding out about it. And ever since then, I've considered myself to be a servant of women because that was back in 2018. It's 2023. And my story is very, very light compared to some of the women that I've supported as a doula and now sitting as a leader on a community doula program. Like, it is horrible. And so I don't see myself getting out of it because I would think that things would get better, though it has, because people have more access to doulas. There's still so many women who don't.
Thank you for also sharing your personal story. We really appreciate
Oh,
that.
no, thank y'all.
Powerful. It's powerful. It's a real powerful story. And I think it's important to show the passion for the work that you're doing. And we thank you for that work because we definitely need more doulas out there helping Black women. Dr. Burse.
Yeah, and I'm kind of Tara had like a primary personal experience, and though I did as well, I think my entry into this work, I've been in public health for maybe 15 or so years now, and a lot of my work was around sexual and reproductive health, HIV, access to contraception, the range of reproductive health, rights, justice. But I also had very strange turn of events in my family. Though I had great, I had great birth experiences, things here and there that likely could be better or could have been better and improved my experience. But it was more about my family. In 2003, my aunt died 5 days after giving birth, and she was a social worker by trade, had just received her master's degree, 30 years old, excited about having a baby, family as advocates. My mother was in nursing school. My aunt was a doctor, had been out of medical school for maybe 5-10 years at that time. But all those advocates could not save her life and could not speak up with and for her. And in 2016, my sister had a very severe case of preeclampsia, and she ended up having to be transported via ambulance from the place where she lives to here in Jackson, which is about a 2-hour ambulance ride. And so that just lets you know how we only have one level 4 NICU here in the state. And her story, she had very severe preeclampsia, delivered baby at 25 weeks, and he lived for 8 months in the NICU until his little heart and lungs just couldn't work anymore. That same year, my sister-in-law, her and my sister were both 26 years old, very young, so young women. And she was about 28 weeks pregnant, went in for some pain. They did an emergency C-section, sent her home. She comes back in via ambulance. They say she has pneumonia. And she's then put on a ventilator for 3 weeks, and then family has to decide to take her off the ventilator. But that also speaks to issues in the system. So she was a nursing student, undergraduate degree from Jackson State University, family there every single day. I can remember the pulmonologist saying, well, she has age is on her side because she's young, so these lungs, they can rejuvenate, but what's not on her side is weight. She's severely overweight, and and those things are what we try to teach professionals to be more sensitive about and around victim blaming in these in this area. And so I was still working in sexual and reproductive health, and I started thinking, okay, now I know this is a strange set of circumstances for my family, but there's this bigger issue at play. So, then comes Serena Williams, Beyonce, all these other women who had resources and even more resources than we, had, way more resources than we had. And they still had near misses or, all these cases. And so I just shifted my focus, which was a likely evolution in the work, but just shifted my focus to solely maternal health and looking at the social justice part of it.
So Nikisha, I was wondering if you could talk a little bit about, both of you, but start with Nikisha, about how this falls squarely in the reproductive justice arena. Explain a little bit what reproductive justice is and why it's so important for us to include and think through this maternal health crisis as part of a reproductive justice issue.
Yeah, and when I look at it from a reproductive justice lens, that's taking away your bodily autonomy, your dignity, and even your ability, well, even listening. So that's like very all the way down in the, it's just I guess a byproduct of all the things that happen in the system when you go all the way down to listening. But the justice part of it is when we, encounter systems where providers dismiss, and I'm not talking about just dismissing us in one-on-one interactions, but you have layers of people in many cases where they are, saying, well, what about this? Can we consider this? Can we do these things? And it's completely dismissed. And so that when you think about do no harm, this Hippocratic oath that you take, often that's thrown sometimes, and I can't say all the time, but that's thrown out the window because of what someone looks like, the color of their skin. And so that lens, when we're looking at Black women, and as Lillian stated, it's not an escape. Education, income, none of that escapes. And an article came out in 2016 where providers said, they took this survey and said, they have issues around, well, they will think that Black people have a higher tolerance for pain because of thick skin. We've probably all read this. And that was a 2016 article, okay? And so, but if you read Medical Apartheid, Killing the Black Body, these same things happened in 1619 when enslaved people were brought to this country. And so how much have we evolved? We have medical advancements, but at what expense? The Black body. And so with our bodies being used so much as experimental tools, then there's no value placed on that body outside of a commodity and a product. And so that's a lot of how we try to look at it. We don't separate what we see in these numbers from history and the historical impact. And that justice lens is not there yet. We're not there. There's still so much further to go, but I'm definitely hopeful about, especially with all the work that's being done, the work that Tara does with doulas. I'm hopeful.
Tara, talk a little bit about how the work you're doing with doulas is contributing to this reproductive justice and the support of birthing people, particularly Black birthing people in Mississippi, but beyond.
Okay. Yeah, first off, Dr. Bird's mic drop, that was perfect. And so we have a community based doula project that started about 3 years ago. 2019 at the height of COVID. We did not have a clue of what we were doing. We were just out here doing it. We knew that there was a need. And so we were just like, we're going to fill it. And so when we started, I was a doula in the project, and now I'm over the team, but I got an opportunity to work alongside with during the time. And so we serve African-American women here in the state. We've served almost now, since we started back up, almost 300 families. And that is huge, because I wouldn't think that I would be here talking with you all, or to say that we've served that amount of families, because people still don't really understand what it is in the scope of work of what doulas do. And so to say that is one particular thing, I could not say that. The project originally started out as wanting to have this one cookie cutter type of focus. We were only going to focus on, the mom. And so we quickly found out, especially with me coming with my background as being a doula, I realized we had to make it very unique and create a individualized program rather than just focusing on the mom, because a doula is really there for everyone. That can be auntie, auntie, cousin, whoever is involved, and they're on your birthing team. And so we're doing a lot of educating. There's so much information out there, but there is so much wrong information out there. And then also when we're talking about the state of Mississippi, what you get here, our climate with maternal health is completely different if you're on TikTok, Instagram, looking at people in California and New York. That is just not what is going to happen. And so we educate women a lot because, like Dr. Bird stated, with there not being justice and reproductive justice, a lot of women are disconnected from their bodies. And so they just really don't know that they have this power. And then they also don't realize that they can, advocate for themselves in this way. And so we're educating a lot. We're allowing women to know that there are things, there are resources out there, there are tools, there are ways to get around a lot of things. People just don't know. And then other than that, we're also just making sure that we're holding their hands in these spaces because women have a lot of anxiety. A doula, a lot of times, is just holding space. I mean, I sit in delivery rooms with women all the time, and it is very comforting for her to look over to know that I've been with her along the way, but also I'm right here. And if something happens, I don't even really have to speak because I've done my job. And now I'm just in the room giving her that reassurance of like, hey, there's somebody here on my side. If I ain't got nobody, I know that I have Tara. I know that I have this doula where she will educate me. She will not rush me. And so that is very, very reassuring. And so I couldn't give you one specific thing, but we kind of have our hands in everything. But a lot of what we do is really, really educating women, because you'll be surprised at what women don't know that they have the right to do.
And also too, I think, Tara, you're making such a good point. Like, we just assume that women know, like, I get pregnant and I know what to do, right? Like,
No,
who taught
no.
you that? You've never been pregnant before. Even women who have been pregnant before, every pregnancy is different, and so this assumption that, okay, you're pregnant and you're going to know what to do, and that you should be able to ask all these questions that to help you, it is actually a falsehood, right? What's needed is what's going to happen. You hear so many pregnant women say, like, I had no idea what's going to happen to my body. I had no idea that X, Y, and Z happens. I had no idea that I was going to feel this way. I had no idea about that. And part of, I think, the utility and the brilliance of doulas is being that trusted voice for a mother to ask the questions that or a birthing person to ask the question that she may feel she can't ask her physician, right? That she's embarrassed. I was supposed to know this. First of all, you're not supposed to know any of it, right? But also, we also have to, it's part of our American health system, and we're going to have to deal with that. We also have to acknowledge that the health system, doctors don't always have the time to sit and answer an hour's worth of question, right? Because they have, 15 minutes, 20 minutes, maybe half an hour, and they're trying to do the best with the system that they're in. But the advantages of a doula is that they can take the time and say, well, let's investigate that. Let's figure it out. Here's the questions you need to ask your doctor next time so that you can get the answer to these questions. Because sometimes it's hard. It happens to all of us. We're just like, they're a doctor. They know the answers. I didn't go to medical school for 4 years. So what is that? I also want us to talk about, like, what do we feel? And I'm getting into kind of structural racism and social determinants of health. Like, why are we here? Like, let's talk about why we're here. Let's elephant in the room. We can be as free as we need to. Why are we here?
I think that's kind of furthering the reproductive justice conversation. It is not that we have so many horrific providers. We have some horrific providers, but we also have some very amazing providers. But the system, the American healthcare system, was not designed to value our bodies. And so even when you look at sterilization, who was a part of that? And so then when we now look at all these fibroids and hysterectomies that Black women have, when there may be other options that are less invasive, are we even offered those? Even there are some medical indices around diabetes that don't even measure us the same, and so I think it's really a lot about how, if we go back to that study about brain size and skull size and all that thing, that's where this started. It started because when we came to this country, not by our own will, We were never viewed as a human being. And so then that gave white people the opportunity to use our bodies for whatever they saw fit. Is that labor? Is that caretaking? Is that medical, advancing medicine? And so that continues to be perpetuated. So then you get to medical school. And first of all, how many HBCU medical schools do we have? I think 2, maybe 3 now, maybe 3. And so what happened? Well, as we brought our midwifery practices from, our homeland, we brought that all here. And we use those practices not only to care for ourselves, but to care for those who in that time owned us, right? And so as medicine begins advancing, people are practicing medicine and perfecting these procedures. This report, the Flexner report, comes out to basically standardize medical schools to say, these schools are up to standard. These are schools that you should go to. And so what happened? They knocked out all of our medical schools. And so then we don't even have a place to be trained in medicine for ourselves. And Flexner wasn't even a medical physician. He was like an educator. So, who gave you the right to do this? And so then we don't have medical schools. So we talk about, well, we need more medical providers that look like us, that can work with us. That pipeline, where we're trying to groom healthcare professionals, it's fragmented for Black professionals. It's hard to get into medical school, those applications and all those things. That's one piece. Then when they get there, they're educated in a way that says, oh, Black people got thicker skin. This is how Black people respond to pain. Well, they may not respond in this way and someone else does. Or if they come in, then they're seeking pain medication. And so then there's that piece of it. And then to say midwifery was wiped away pretty much after that. And so we still don't have all of our practices. And even thinking about breastfeeding. So, these studies say, well, as Black women got advanced in society, they started buying bottles and buying formula. That's a sign of, your social status. You're moving up. But no. We were disconnected from the act of breastfeeding because we had to be wet nurses. And so it's all these historical events that got us here. And I have 5 generations living in my family right now. My son up to my great grandmother. And in that line, I'm the only person that breastfed. And grandma didn't say, or my great grandmother didn't say, well, my mama was, X, Y, and Z, or she had the wet nurse or something. No, it was just passed down. We just didn't do it, and so we get disconnected from that trauma. And then the data tells us, well, y'all don't breastfeed and you need to breastfeed more, or you don't seek prenatal care like Lillian said, but you live in an area where you don't even have but maybe one provider and the area is already poor. And so those are the things that we're dealing with here in the state. And then it jumps all the way. We get real bold about racism. In Mississippi, we haven't expanded Medicaid. I think they're one of 10 states left, 10. And then this session, our governor just signed into law postpartum extension. Now, he didn't have to do that through legislation. He could have done that with a stroke of a pen, but he did not. He chose to let it go through the legislative process. But he has been adamant about not extending postpartum care. And the language that they use is, we're not extending Obamacare. We have been clear that there's a difference. And so what does that also tell you? That ties right back to race. And these are, and excuse me, because I'm on a soapbox, these are Trump Republicans. We're not talking about the Republicans that we grew up knowing. These are Trump Republicans. So there's this very overt sense of racism. And this state is proud to have led the charge in overturning Roe versus Wade. And so race is at the heart of all of this, racism, and what people think that Black people do and do not deserve, and who has the power to change that. And people, and I see people on social media saying, why y'all even still live in Mississippi? What you want us to do? Just up and run away? You know, everybody, y'all got the same problems in California. They just haven't gotten there yet. You know, so whatever happens here in the South is going to happen across the country, because this country was built on racism, and it was built on the backs of Black people, and Black people not being valued as a person, as a human being. I had a professor, this is the last thing I'm gonna say, I promise. I had a professor, and he was a white man from Texas. He said he would always introduce himself as, and this was at an HBCU. He wasn't a professor, we worked together. He was the associate dean. He would always say he's a recovering racist. And so that rubbed the students the wrong way. And one day I told him, I was like, look, you need to stop introducing yourself that way. Like, you need to give some context, because the students are not feeling it. And so he said what happened, he was racist to his core. He was raised that way. And the way he was raised, he said that he didn't know where Black people fell in this line of like personhood. So he knew that there were white people, there were people, and he knew that there were animals like horses, you know, cows, dogs, but what was a Black person? So he said his family didn't even look at Black people as people. And this man is still living today. I mean, he's elderly, but he is not down and out elderly. Like, you know, not, he's moving around and still teaching. And so he said and he encountered in the military a Black man, and they kind of bonded. And so that's when he learned more about, you know, race and racism and how he was born. And he kind of committed himself to being better. But, you know, and that blew my mind, but that's what it is. Sorry, I took forever. I get on my soapbox.
I think it's perfect. I think the points you brought up so many different points. I was trying to remember them, but I'm going to go through them. That, you know, Dr. Bercy talked about the racism, the structural inequities that are built into our systems, right? You know, how even our education is perpetuating the racism within the medical field. And one of the, you know, there are, I think it's 3 Black HBCU medical schools. But the interesting part is that the number of Black physicians, though our populations in this country has increased, has stayed the same at 3% since 1970 or 1980, right? So still, in this country, only 3% of African Americans are MDs, right? And so when you're talking about combating the problem, about making sure we have doctors in the community who understand the community to help the community, it's impossible when their numbers are so thin, right? It's impossible. Even if every single one of them went back to the communities they came from, there's not enough of them. And so that's a fundamental problem of the structure of the system in creating this problem. The second problem, I love the example you gave about the breastfeeding, because I think it's important that it's not just about not being learned. We also have Black women in positions, in jobs, in areas in which they cannot, right? If you are working at, you know, a low wage job or on an assembly line, even if you're making a lot of money, if you're working at an assembly line and you don't have time to go pump and there's not a breastfeeding room, it's going to be hard for your milk to continue to come in. And because most Black women, what you were talking about when you're talking about your grandmothers, even if they weren't wet nurses, if they were going out to have to work in somebody else's house and take care of somebody else's children, they didn't have time to breastfeed their own children. And so their milk dried up. And so it's important to understand that the economic circumstances that this country has created for Black women has not allowed Black women to have the birth experiences that other women have had. And so it's a combination of this structural racism, this lack of access to care, but also economic and environmental factors, where they live, what they have access to, that has prevented not only, for example, access to doulas, but access to the resources they need to deliver and support their child in the first year the way other women have. Tara, I'm going to let you go because I think that's important. You had all those points, but I want to make that through line, and that's the justice through line. Even, I'm sorry, Tara, before you go, this point about Roe versus Wade being overturned. I know a lot of people are like, it's not a big deal. It is a big deal, right? Because now you are having women who did not want to have babies, who may not have the quality of life, the economics, or the physical ability to have. I mean, they're even preventing people who are sick. It's not even that they're just don't want to have a baby and they were quote unquote irresponsible. Women who cannot carry a baby to term, carry a baby to term. You're putting their life at danger. You're putting the baby's life at danger, but you're also now having more people come into a system, more babies come into a system to parents who were not ready to have them. And that becomes a justice issue because now you are essentially forcing somebody to put themselves in a place that that's not easy for them to live in. And so Roe v. Wade is not only a reproductive justice issue, it is a maternal health issue because we are going to have more people who are not going to get the right access to care and who are going to not have good maternal outcomes. So Tara, go for it.
Yeah, and just on the Roe versus Wade, I feel like we're already seeing the impacts of that now. I know our project is because you have this influx of moms who are now carrying these babies when they would be having the abortions. They're coming in. And what we're seeing that the clinics are doing in our area is they're pretty much telling folks you can't get into the clinic unless you're 8 weeks. That to me is a red flag because moms in the state also have all of these pre-existing conditions even before they get pregnant. And now they can't get on a monitor. Now they can't get checked out until they're 8 weeks pregnant. And so, as Dr. Bird said, something that we've been really, really doing that has been beneficial is funneling these moms over to midwives. We have more midwives now in the state than we've had in a very, very long time. And they're here in Jackson. And then we have some in Hattiesburg, some on the coast, and just getting moms acquainted with these midwives who are taking these moms, whether they have Medicaid or not, to give them OB care has been amazing because they would not. And then trying to hold their hands because this option is not there for them anymore, and trying to get them to be in a place where they are comfortable, where they feel like they're secure because they're just like, I don't have any money. I don't have any resources to take care of this baby. And that's just one person. And if you're a doula, you have anywhere from we have a doula on our team. She has 22 doulas just in 22 participants or women in her that she serves. And so that's not including any private pay clients that she takes. So for a mom who is put in a position where she has to have a baby against her will, she does not want the child, then that is a lot on that doula. And so I'm most concerned about it being a burnout. Doulaing is very, very tough. Doulaing is tough, and also for my providers and my nurses, because I get an opportunity to talk to them now. It is burnt out. It is a burnout for them because they are now taking care of these moms. And we think about when we get into this work, oh, we're just providing them a service. It becomes where we become family-like to them. And they are very, very heavily dependent upon us. And so it is really wild what we're seeing, and it is heartbreaking. And it is putting a lot of moms at risk, and they were already uncomfortable. They already have anxiety, but now it is through the roof. And I'm trying to get people connected to therapists, but that's a whole nother conversation because it's just like they can't afford it. My therapist, I know it's $250 for our session. And so I'm just like, people don't have money for that, and then bringing on a child that they couldn't afford in the first place. And so there is a lot of ramifications with this that I don't think that we've thought. Like, I think, politicians might have thought we're not going to see the effects of these maybe 3 years in, but we're already seeing them here. Even we have some of our moms going to desperate matters to take their child, themselves. They're going to the midwives, asking them, are there certain herbs, or they're looking up stuff on the internet, or buying these pills that are not safe. And so when things don't turn out the way that it should, we're trying to get them connected to a provider because we're just like, you put yourself at even more risk now that you went and just took something and you didn't know what you were taking. But I understand when people get desperate, they get desperate. And that's where our doulas and I step in to help, because I'm with you regardless of your decisions. I'm there holding your hand. And so I think that's the advantage of birth workers, of midwives. We're kind of out of the system. And so we're really, really here to support regardless of what you want to do. And I think that provides a lot of security for moms, because I think when we're looking at the traditional health system, they don't really have that. You can't tell. We have moms where they are smoking. They can't tell their provider that they're smoking, but they've told their doulas this because this is the only thing that helps me, and I don't want to get on medication. And so again, that's that security that moms don't always have, because we can't act like it's not happening, because it is. And so do we let you just do anything, or do we tell you and give you that evidence-based support to show this is what could happen if you do choose to take this route? And so, yeah.
I love that. I love that. So we have about 12 minutes left, and I do want to get, just in case people have questions, but the last question. So we spend a lot of time, it's a little bit of doom and gloom, because it's a serious topic, and it's a heavy topic, and it's an important topic. But I know the two of you in particular have been actively working in the state of Mississippi to make things better. And I think, Tara, you just talked about the work that your doula organization does and how they support women. How can we make this better? I mean, besides changing the system, we know we're not going to change the system. That's blow it up, start all over. We can't do that right now. What are the ways in which we can help and support, women in making sure they have good maternal and good birth outcomes? Can we just talk a little bit about, a lot of the folks on this call are our affiliates. They're in the community. They're seeing people who are maybe coming in for housing counseling, but are also pregnant, who are coming in for, entrepreneurship interest, for coming in for workforce development. But, if they're coming for workforce, the father may have a girlfriend or a wife at home who's pregnant, and they're, trying to help, their partner out. So what can we do? Because I always do slightly like to end things on a good note, hopefully, that, there is a light. And I think Lakeisha made a really good point that we are getting better care. We are getting this topic is coming up. Like, as I was telling the group before the larger group came on, I was just on a call with the American Hospital Association about this exact issue. So it is in the zeitgeist. People are thinking about it. People are concerned. I don't know if they're concerned enough about it, but there at least is concern. And so how do we help build the momentum to drive toward positive outcomes?
So go ahead, Tara. You go ahead.
I think it is all about getting back to collective care. I feel like all women need a village, and that's what I'm trying to build. That is what I've, dream of. When we get a woman, I heard this on a webinar I was on about a year or so ago. It's important when we're giving women information that we need to give them information when they can hear it. And so even if they have a doula, we tell Black women all day, like, I feel like doulas are now becoming like CNAs, because it's like all the issues are piled on doulas and midwives, and that's not fair. But even if we give a woman a doula, that does put her at an advantage. But also, if she has all of these other issues going on, domestic violence, her issues with her provider is just horrible, she can't pay her bills, all of these things, it doesn't matter what that doula is saying. As we're sitting there talking to that woman, she's thinking about all the other stuff that she has to do, has to take care of, and now she's pregnant. And I got this doula talking to me about breastfeeding, and I don't know how I'm gonna eat tomorrow. And so collective care is really sitting down with women and figuring out what they need, and then getting them what they need, where they're not funneled through a system where they have to call their provider, they got to call a nurse, and then the nurse got to call them back, and then the provider may or may not talk to them. It's making sure that when women tell us that they need something, that we're able to get them that as soon as we can. That's having therapists on hand. That's having doctors that don't just talk to them when they're in the office. But I love events where we get to do where providers come in regular clothes and they sit and talk to people, because we don't realize our providers, our nurses, they are women too. And they're usually feeling the effects of this too. I have some great providers where they're heartbroken about some of the things that are going on, but they're only one person. Making sure that we have diaper banks. We're supporting the people on the ground that's doing the work, because this is hard work, but it's also hard work. There is so much that goes into this, and we give so much of ourselves as we're doing this work, and it's heartbreaking, because how many stories can we hear where things could have been prevented, where it's just like, does it even feel like I'm doing something? I know that is the case for me, where I constantly feel like maybe I should get out of this because it's not enough. And so the reassurance also for the people doing the work, the birth workers. So we just need to get back to that, where we're being villages for our women, because it's so much that they need. But we can't just throw doulas, throw midwives and all of this when we're not addressing the whole woman, the whole family, because our families as black people, we have a lot of trauma, we have a lot of damage. And if you don't think this doesn't show up during your pregnancy, during your birth, then you're wrong. I've had women where their labor actually stalls because they have trauma that they have not, sexual trauma that they have not worked through. And I tell people, if you do not work through it now, it is going to show up during your birth. And some of these stats that we look at, it's not telling the entire story. And so I'm all about getting people out there, getting people in front of the camera, because as people tell their stories, it's very, very healing. And so that's just on a side of a programmatic thing. When we're out here, collecting data from people, we need to make sure that we're telling the whole story, because I'm pretty sure that it's layered. It's not just this, you ask a question. We need to get stories, and then we need to share these stories to figure out what's going on. And people who are getting into this work, it's grants and that's all of this money out here, but you actually have to care, because to do the work that I have to do, you can't sit behind the desk. You actually have to be on the ground. I am very honored and very privileged to be able to work from home, to go to people out in South Jackson, to sit with them, to talk to them, to bring them their stuff, because they don't have transportation to get it. We think just because we have it out here in the community, people are going to come for it. No, they don't have a ride. So as a leader, you have to be willing to go and put yourself in uncomfortable situations, because you may be their saving grace. So I can talk about this all day, because I truly feel like we've gotten to a place as workers, as public health people, where we're kind of distant from it. But in order to do this work and to impact change the way that we need to, you have to really, really have a heart for your people and be willing to go outside of yourself, because we're making generational impact. That's what our project does. We're saving moms. And if we're saving moms, we're preventing children who will not have to be raised in a way where they're grieving the loss of their mother, a husband grieving the loss of their wife. And then we have to tell them, you got to take care of this baby. That is very, very hard to do. And often after they have that baby, that community and everybody that was there for the baby shower, they're not there. They get tired. And so you have to deal with that. And so we see that things just progress and information is not shared, because we're so boggled down with damage and trauma that is not being addressed.
All right on. I love it. Go ahead.
Yeah, and I won't add much because Tara said it all. So the only thing I'll add is from where we sit in community-based organizations, meeting those basic needs, those social determinants, whether it's, diapers, formula, what food, whatever you can meet, but also just being a happy face and infusing joy in wherever you can will be helpful when people are, experiencing a range of emotions and life experiences.
I love that. Thank you, Nikitra. I think what's wonderful about this is I think both Tara and Nikitra really hit on the point of we have to support each other. We have to reduce stress. And I love that we talked about therapy. I'm going to always champion therapy, because we do have to address our traumas, because what we don't think or don't always know is that mental trauma gets embodied in your body in physical ways that people don't always realize. High blood pressure, heart disease, bad birth outcomes, not being able to do stuff, that is all also with stress. So I think that the point that Tara was making about, women, particularly in Mississippi now, who have to, carry unplanned pregnancy, that's additional stress on their body besides the stress of being pregnant. Because we all know that pregnancy is a stress on the body. It's a great stress. You have this wonderful child that comes afterwards, but it is a stress on somebody's body. And so they have the additional stress of, I don't know how I'm going to have to take care of this child. I don't know where I'm going to eat tomorrow. That is a stress that impacts then not only their maternal process, but their birthing process. And so we really have to think, I love what you said, Tara, about building this caring village around people, all of our people, because dads need support too. They need the support to be able to help moms get through all these physical changes happening in the body. And so, what we have to do, and one of the wonderful things, I'm trying to bring it all together also for the folks on this call, is the National Urban League and the Urban League affiliates do the work of social determinants, do the work that Tara and Keisha are talking about. We help people with housing. We help people find jobs. We help people find rental assistance. We help people find food. That work that you're doing is justice work. It is maternal reproductive justice work, because you're supporting a woman, a family, a child in getting access to the resources they need to live the best life possible. And so for us to always think about that, all the work we are doing is maternal health work. And it's important for us to stay and understand the connections between the social determinants of health and what is impacting the moms that Tara is seeing and her doulas are seeing, and what's really bothering them. Because I think the wonderful part you made is that, you've given them health information about stopping smoking. And she's like, I don't know if I'm gonna eat tomorrow. You're trying to get me to stop smoking and take a patch. Like, I don't got time for that. The smoking is a thing that is the stress release. So how do we help her replace that stress release with a different type of stress relief, right? And that is a support that, and we are seeing these clients in our affiliates all the time, and they may not be coming for prenatal care or stress relief. They're coming for housing assistance, but our eyes being in the community, having access can then be that resource to get possibly them to a group like Tara's, to get them to say, hey, are you getting prenatal care? Do you have access to a provider? You know, do you need some help with whatever it is? And I know that particularly the Mississippi Urban League does a huge mothers, they have a mother's pantry where they have diapers and clothes and all sorts of stuff for mothers who can afford to have that. So I think for us to think through, how do we use the resources that we already have to provide access, or at least resources or information to the communities we have? I'm going to give you one of the final words, Tara.
Yeah, as you were speaking, it just came on my heart. As we create these programs, I think it's important for us to be willing to pivot. I can say with our funders, they have been very, very willing to listen to the things that I have to say, because I have that experience. I know not everybody is able to have that opportunity, but a lot of times as we're thinking about these programs, as we're writing things down, they make a lot of sense on paper, and then we talk to the community. It's like, we don't need this, what you're trying to do. And so you have to be willing, you have to be flexible. And if you're a program or your organization being funded where they don't have that flexibility, I feel like it's our jobs to allow them to understand, to make them understand that this is what the community needs. They don't need this is what they need. And so we have to be flexible in the work, because what the community does and what the community needs changes all the time. And we have to be willing to meet that change if we want to see upward momentum.
Dr. Burse, final words.
And I'll push my final words toward the question that was in the chat about the local affiliates. Our Urban League, I don't know if anyone is here from that, but they're, like you said, diapers. They used to have a clothing space for babies. They do education around, for families. They have a food pantry, had a garden, and there was even an exercise facility. That's on top of all the other things. So when we think about these social determinants and meeting people's basic needs, like you said, Lydia, you're already doing it. But if there's something else, if they're only using the food pantry and they're not coming to work out, then maybe they could come use your facility just for 30 minutes to exercise, or whatever it is, whatever needs you can meet, just meet it, because you may not be a healthcare provider, but what you are providing is, what you're doing is creating more avenues and tearing down some of those obstacles and barriers that people face. And that's worth more than anything. And so I just encourage people just to keep doing what you're doing. And like Tara said, if something else comes up that you can do, don't be afraid to add it on if you can. If it doesn't, take too much resources and space, do it.
I think we're going to end on that. That's the wonderful thing. And exactly, it is that we have programs that cross-pollinate all of this stuff. And so just making sure that your clients and the people you serve are aware of all the resources that the Urban League can provide them, but also think through other ways in which you can reach particularly mothers and helping them and supporting them in this birthing process. Before, during, and after, because it's not just when they're pregnant for those 9 months, it is before, during, and after. Can I just say, I'm so honored to have been moderating this panel with you, two beautiful, wonderful, just enlightening women. And so I'm just really grateful for you all being here and for sharing your knowledge with the Urban League and the Urban League audience. It is now 1:01 Eastern time, so I want to make sure I'm respectful of people's time. Thank you so much. We will be sending the recording and the PowerPoint out to everybody, and this also will be on our YouTube page. So thank you so much. Let us know if you need us for anything, and we just appreciate you so much. And keep on fighting the good fight, because you all are fighting the good fight.
Thank you, and it's been a
Thank
pleasure.
you.
Have a great day, everybody. See you next month.